Okay, it's almost a minute after 2, so I think we can go ahead and get started. So good afternoon to everyone. My name is Aaron Leposki. I'm a program director at the National Center on Sleep Disorders Research at the NIH, and I'd like to thank everyone for joining us for this biannual Sleep 101 Symposium. Today we'll highlight various advances and opportunities in sleep and circadian science and research. And the specific topic today is sleep health across the lifespan. So before I introduce the panelists, I'd just like to remind everyone that your audio is muted and your video is off. We encourage you to include any questions that you might have on this topic or that you come up with from listening to the presentations in the Q&A on the Zoom platform. And then we'll have time after the speakers speak. We'll have time at the end for a discussion session, and we'll look through those questions at that time. So in terms of the seminar today, we'll kick the presentation off with an overview on developmental trajectories in children's sleep and sleep disorders by Dr. Julio Fernandez Mendoza. Dr. Mendoza is an associate professor and associate vice chair for faculty research development in the Department of Psychiatry and Behavioral Health of Penn State College of Medicine, as well as a clinical psychologist and board certified in behavioral sleep medicine at the Penn State Health Sleep Research and Treatment Center. He's the director of the accredited behavioral sleep medicine training program, and his clinical practice focuses on sleep and circadian disorders. His research uses population-based designs and focuses primarily on the trajectories and natural history of sleep biomarkers, phenotypes, and disorders across the lifespan. Their association with cardiometabolic, neurocognitive, and psychopathologic morbidity and mortality. So the floor is open to you, Julio, to begin your presentation. Thanks.
Thank you very much, Aaron. It is a real pleasure to be here to share a little bit of what we do, what we think needs to be done, and what can be done. So my focus is going to be today and starting in children. But as Aaron mentioned, I wanted to give a developmental perspective on this so that my presentation links a little bit better with my colleagues later on that are going to cover other developmental stages. So today I will talk about the sleeping brain. So what can we measure with the sleep EEG, with the electrodes that we put on people's scalp, including youth, to measure their brain activity while asleep. And then I decided to focus on 3 phenotypes that are most prevalent in children and how they develop, or how they, what the natural course is across the lifespan: insomnia, sleepiness, and sleep apnea. And of course, I will touch on opportunities to advance what we know. I don't have any conflicts of interest to disclose based on the criteria set here. And our learning objectives today are to basically identify prevalence of different sleep phenotypes, understand the natural history as well as developmental trajectories, identify or recognize social determinants of health, behavioral, and biological risk factors, and also pinpoint opportunities to advance our work and improve human health, which is our aim since childhood. So why the sleeping brain? Well, many of you and those who can Google and go into Wikipedia can actually access this type of information. As sleep experts, we have worked with the brain activity to identify when someone is awake and when someone is asleep, and then in which sleep stages they go through the night. So we have identified very well what is the brain activity that characterizes specific sleep stages. By the way, nowadays we merge stage 3 and 4 into one single category of N3. However, we've for years and decades actually known that there is specific brain activities such as sleep spindles that occur typically during, or allows us to score stage 2 of non-REM sleep, that are tightly related to sleep integrity. So they have a sleep protective effect when the brain wants to go into wakefulness, and it helps consolidate the sleep period. And then we know that a slow wave activity, or slow waves, are related to sleep intensity and homeostatic sleep drive. So we know that if we deprive someone of a sleep, the following night, what that brain is going to do is actually increase slow wave activity. And nowadays, other people have developed a standardized sleep EEG biomarker. So above and beyond this type of activity that you can see here, spindles ranging in between 11 and 16 hertz of brain activity, or a slow wave activity being on the slow wave on the slow end, obviously 0.4 to 4. Some individuals, like Dr. Yunes, have developed something called the odds ratio product. And this is because many of these metrics that I mentioned before are very subject or sensitive to the settings that you establish when you actually perform the sleep study. So things such as the odds ratio product and other standardized sleep EEG biomarkers out there in the field help us standardize the metric of what would be biologically poor or good sleep death. And what happens is that the sleeping brain changes a lot with development. And this should not be very surprising, because already Feinberg, back in the 80s, a sleep expert that passed away, unfortunately, a year ago, he already called our attention that the brain actually matures in a very specific way. This is a classic data from Huttenlocher showing how synaptic density increases since we are born, peaks in childhood, and then it starts to decrease, which is called synaptic pruning. Basically, there is a pruning of synapses in the brain with maturation in adolescence that then becomes stable. And he called our attention, and Ian Campbell and other people, including Mary Kerskaden and Rito Huber in Switzerland too, actually describe in smaller samples something that we have been able to observe in a general population sample, as Aaron was saying. That's the models that we use. So in 572 subjects from the general population, we were able, I know many of you are thinking, well, it's a shame that you don't have newborns 1, 2, 3, 4, 5, but science is not perfect sometimes. But we were able to identify that indeed the trajectory of a slow wave activity with age mimics that of synaptic pruning or synaptic density, reaching in our sample a peak at around age 7.4 and a sharp decline in adolescence. And what is the importance in terms of human health to understand this type of trajectories? That these trajectories are affected, or actually are biomarkers of psychiatric, behavioral, or neurodevelopmental disorders. So in the same study, we found that typically developing youth, so subjects that had never ever had a history of a neurodevelopmental psychiatric behavioral disorder and had never been medicated, had a peak in a slow wave activity at around age 7, like in the previous sample. And then what we found is that youth or subjects with unmedicated psychiatric or behavioral disorders had a peak in the slow wave activity about almost 2 to 3 years later. And who were those children? Well, it was actually children with unmedicated ADHD. Remember, this is a population-based sample. So ADHD is highly comorbid with learning difficulties. Many kids in the general population, not necessarily in clinical samples, when they go to school, they get a diagnosis of some sort of learning problem. So that's the comorbidity that I'm highlighting here. Regardless of that, you can see that unmedicated youth with ADHD showed a maturational delay on a slow wave activity, and actually a topographical disruption. You can see how typically developing children, they had a peak in the slow wave activity in the central region and then a peak in the frontal region. We want to see that in normal development. We want to see brain maturation moving forward. This data actually was recently replicated by Darsha and colleagues, Ian Campbell's group, in a very nice study with 18 subjects with ADHD, where they clearly show longitudinally this maturational delay. So importance of sleep EEG biomarkers that are able to capture something that is going on with these children with neurodevelopmental problems that otherwise may not be captured with just simply a clinical interview or even a natural and a standard sleep study. Sleep spindle activity, as I mentioned before, is also critical in understanding sleep from its sleep integrity function. And one of the things we found in our population study was that the peak in a sleep density, so this is the number of spindles per minute of sleep, occur at around age 15. So children experience an increase in the sleep spindle activity, and the peak is about age 15, a finding that was simultaneously replicated by, again, the group by Ian Campbell. We like replication in the era of lack of replication in science, where Zhang and colleagues, they reported a peak age at around 15.1 years. So pretty much the same data. And why are sleep spindles important above and beyond what we can know from sleep disorder data? Well, many people in the field have established that in typically developing youth, sleep spindles are tightly related to intellectual ability. So in our cohort study, and this is the baseline portion, the 700, 639 had valid sleep spindle data. And we found that indeed we were able to replicate in a general population sample that those children, this is age 5 to 12, median age 9, with greater number of spindles per minute of sleep, they had better IQ, they had a higher IQ, and also other type of cognitive metrics such as executive functioning as measured by working memory task, which is the digit span backwards. So very clear data showing how sleep spindle activity above and beyond, this is data adjusted for sleep apnea, insomnia symptoms, and so forth and so on, can index cognition, even general population samples. And I mentioned the odds ratio product. That's the standardized biomarker I've used in my research. As I said, there are many others out there. And what we found, you can see this, right? The ORP is meant to index sleep depth. And it has a completely different developmental trajectory than sleep spindles and slow wave activity. This is good. This means that it's measuring something different. Probably a slow wave activity because it's highly controlled or has a local control, right? It expresses locally in the cortex, has a very different trajectory, while the odds ratio product, which is this standardized metric, may be capturing more global control of sleep and wake. There is a linear increase, and also there is a very interesting issue that is specific to some psychopathologic dimensions. So in our cohort, we found that frontal or front-occipital derivation for slow wave activity and ORP related differentially with externalizing behaviors on internalizing symptoms, so that lower sleep intensity, in other words, lower slow wave activity, was associated with more externalizing behavior in children. So this is rule-breaking behaviors, oppositional behaviors, while lower sleep depth, so higher ORP for the developmental age they're in, more internalizing symptoms. So poorer sleep depth, more anxiety, more depression, lower sleep intensity, more externalizing behaviors. This is very interesting data, and today I wanted to present to you interim analysis because I thought that it was a good forum to talk about things of where we are going with this data and not just publish one. When it comes to insomnia, we've known a lot about insomnia symptoms in children. And in our study, consistent with a prior study by Tom Roth's group back some years ago, that it was retrospective data, we were able to find with prevalent data, this is the entire sample, 700 children 5 to 12 years old, that indeed the prevalence of insomnia symptoms increases at around puberty in females. So females are more likely to report, or their parents to report, insomnia symptoms of difficulty initiating or maintaining sleep. It's exactly where that slope is starting to occur. And by the way, something I didn't mention, but that slope in a slow wave activity occurs earlier in females because they mature earlier. And these type of insomnia symptoms are not just related to anxiety and depression. It's not that women are weak, the opposite. What is going on here is that increased prevalence is because these females are already starting to experience insomnia associated with in-lab polysomnographic objective sleep disturbance. And where do they go? That's the question we want to answer, right? What happens with this insomnia? And this is exactly what we published in 2 papers. One using the adolescent transition, but still this is childhood to adolescence. And then another paper using our current follow-up in 500 of these 700 children, in which we've been able to follow them up to young adulthood. The prior data on sleep EEG biomarkers, thanks to NIMH funding, this data thanks to NHLBI funding. So what we found? In the transition to adolescence, and remember, green stands for children, we found that 30%, only 30% of children with insomnia symptoms fully remitted by adolescence, and about 56% of them persisted. Then in adolescence, another third newly developed these insomnia symptoms. And this is by self-report now that they are median age 16. And what were the main determinants of this natural course? Well, first of all, social determinants of health. Again, females were 2 times more likely to persist with childhood onset insomnia symptoms in the transition to adolescence and to newly develop insomnia symptoms in adolescence. Remember the pubertal effect. But here's the important data, and this is surrogate because we don't have measures of perceived racism and the like. Black African-American children, median age 9, they were 7 times less likely to fully remit from their childhood onset insomnia symptoms, 4 times more likely to persist with childhood onset insomnia symptoms. As it pertains to non-Hispanic whites, it was low socioeconomic status that was a determinant of them having 2.5 to 3-fold less likely to fully remit and more likely to persist. Very important data in understanding how social determinants of health and its upstream determinants actually play a role in the chronicity of sleep disorders since childhood. What else did we find in terms of determinants that had to do with, for example, health? In terms of biobehavioral risk factors, the main one was internalizing disorders. So if a child, green, if a child had parent-reported insomnia symptoms and a clinical history of having been diagnosed with a depressive or anxiety disorder, they were 6 times less likely to fully remit from insomnia symptoms, 6 times more likely to persist, 5 times more likely to newly develop insomnia symptoms in adolescence. So this is talking about the well-known in adulthood comorbidity between mood disorders and insomnia. And this is showing how that interplay occurs very early in life. Pain disorders obviously also played a role in not fully remitting, or at least 5 times less likely to fully remit. And when it comes to biobehavioral risk factors in adolescents, we found that adolescents who were obese had 14 times less likely to fully remit from their childhood insomnia symptoms. And obviously obesity played a very strong role in persisting basically of insomnia symptoms. And one issue that I want you to pay attention here to is that starting to use tobacco in adolescence was associated with 7 times fold more likelihood of persistent with childhood insomnia symptoms. Notice that it did not play a role in the new onset of insomnia symptoms, but it was vulnerable children who were already reporting insomnia symptoms that then became smokers that contributed to the persistence of their insomnia symptoms. Very interesting data from a substance abuse standpoint. And what happens beyond adolescence? Well, this is data from our latest visit in our Penn State child cohort. Before I presented this, and now we're actively recruiting these guys into the lab. This is data from the first 500 that completed a 40-item red cap survey. A bunch of them had already insomnia symptoms. 43% of them persisted with insomnia symptoms all the way until median age 25, 9, 16, 25. And about a third of them, 27% of them, fully remitted by adolescence, and they remain remitted. But what was important in this study too, in our cohort, what we have unique is that we have in-lab sleep studies, polysomnography, as you saw before, because we had a sleep EEG data. And what we found here is that those children with parent-reported insomnia symptoms who slept short in the lab, basically less than 7.5 hours, which was the median in the population sample, were 2.5 times more likely to evolve into an insomnia disorder at age 25. So these children who were objectively sleeping short already were at risk of worsening into a full-blown disorder, while those with normal sleep duration, despite reporting insomnia symptoms, were not at significantly increased odds of evolving into a full-blown disorder in adolescence. I will leave my colleague Sarah Honecker to talk about adolescence as a critical period for insomnia. I don't know why this is not running, so I'm going to go here and click the arrow. And this data, this developmental data, was important because we had previously reported that these children with short sleep in the lab had actually increased cortisol levels at median age 9 and were characterized by increased internalizing symptoms. Remember the data from the sleep EEG biomarker before? So basically, we once again see a very strong connection between phenotyping insomnia and the underlying pathology that may be going on or that these kids are at risk of. And again, This was data that was not serendipity. We have defined in adults very well 2 insomnia phenotypes precisely based on the presence of short versus normal sleep duration. So this is developmental data telling us a lot about the history of these phenotypes and how they evolve across the lifespan. When it comes to daytime sleepiness has been typically considered a symptom, unless you have a idiopathic hypersomnia or narcolepsy, which may be in a continuum for a lot of patients. It is a symptom that is actually also quite prevalent in the general population. My colleague, Dr. Calhoun, she found that in our cohort of 700 children, the prevalence of excessive daytime sleepiness, this is not just complaints of fatigue or a child that is sleepy, this is excessively sleepy, with teachers or supervisors noticing that the child falls asleep in class or watching TV or the like. The prevalence was about 15%. And you can see that once again, the multifactorial risk factors that lead to EDS even in children, not only trouble sleeping or mood and anxiety, but also medical conditions and once again, central obesity. But what was most important is that even in children at that age, we found that there was a strong connection, not just between excessive daytime sleepiness and parent reports of the kid having attention problems in school, learning problems in school, or even behavioral problems, but that this relationship was mediated by the objective neurocognitive functioning that we measure. So this is measured with neuropsychological tests, where what we found in the baseline was that children with excessive daytime sleepiness had worse processing speed, worse working memory, which explain part of the association of the complaint of EDS with the observation of behavioral problems either in the classroom or at home. So excessive daytime sleepiness may be a symptom, but it needs to be taken seriously, at least in some children, in whom, at least in a third of them. This is completely new data, unpublished. I just wanted to share it today with everyone. We have found, as of today, that those children who had excessive daytime sleepiness, a third of them persist all the way through young adulthood. However, there is a high remission of EDS in the transition to young adulthood from adolescence, because EDS peaks in adolescence. So these are 2 completely different phenotypes. These children need to be screened out and identified early on, much earlier than we're doing right nowadays. And then finally, let me touch base very quickly on sleep apnea, because it's a highly prevalent issue and actually is of great concern to a lot of parents and clinicians alike. We do know that a bunch of kids in the general population may have thresholds that are diagnostic nowadays for mild obstructive sleep apnea. But what we have known is that about 1 to 4% of the general population of children would have a moderate sleep apnea. And once again, we do know that there are significant inequalities in the prevalence of sleep apnea, as well as actually prenatal, perinatal, and postnatal determinants of the prevalence, of the high prevalence of sleep apnea so early in life. And what happens with the sleep apnea in the transition to adolescence? Is it the same as insomnia, where we saw a full remission of only 30%? Actually, surprisingly not. The remission of mild pediatric sleep apnea using a cutoff of an apnea-hypopnea index greater or equal to 2 is about 53% in the transition to adolescence. So this means that there are multiple factors that cause sleep apnea, obviously, in childhood, that may have a completely different natural course from those who persist in that transition or those who newly develop in sleep apnea at a high level, at a moderate level in adolescence. What we found is that actually childhood obesity, weight loss, and the pure developmental trajectory of SDB are both involved in this persistence and remission, where one of the issues that we found was that as compared to those individuals or youth that did not have any history of a sleep disorder breathing, vast majority of any of the groups, be it those who persisted with primary snoring, those who worsened into sleep apnea, those who persisted with sleep apnea and the like, but almost the vast majority of them had a high prevalence at baseline of childhood obesity or overweight. And it was the groups that remitted from primary snoring as a milder form of sleep disorder breathing and who remitted from sleep apnea, and this is full remission, that actually had lost weight in the transition to adolescence, while those groups that either worsened or stayed the same, they either gained weight or actually they remain overweight or obese. So these data at the population level was telling us a lot about the association between childhood obesity and the natural trajectory of a sleep disorder breathing. And obviously, this is not good. In a recent paper, we were able to find that that group of youth, of children who persisted with pediatric obstructive sleep apnea in the transition to adolescence, they were at risk of having elevated blood pressure as per American Heart Association guidelines in adolescence. So you can see here, trying to predict elevated blood pressure, hypertension, if you may, in adolescence from purely childhood OSA is not successful. It is the natural course where those who persisted with childhood with pediatric OSA had about threefold odds of having elevated blood pressure in adolescents, even after adjusting for baseline blood pressure. And in terms of the incident cases, you see that this was marginally significant. Well, in the paper, you can read that among this group, because this was defined based on pediatric levels, those with moderate OSA were at about 2.5-fold odds of having elevated blood pressure, which talks about the new onset of pediatric sleep apnea in adolescents being associated with elevated blood pressure. And where are we going now? Well, I show you young adulthood data for daytime sleepiness, young adulthood data for insomnia. Let's look at what we're doing right now, thanks to NHLBI. We're looking at the trajectory, the cumulative exposure of sleep apnea since childhood through adolescence into young adulthood. And now in young adulthood, these formerly children are now, as I said, 25 years old, and we're doing ultrasounds, atherosclerosis, coronary blood flow, and endothelial function, flow-mediated dilation. And what you can see, this is preliminary data from the first 178 that we start examining in the lab. As of today, we have 262. COVID had a huge impact on this study, but that's a different story, like for many people. And we found that these youth with a cumulative apnea-hypopnea index across the lifespan of greater than 3 events or more per hour of sleep were at 5-fold increased odds of having endothelial dysfunction in young adulthood, as per cutoffs typically used in large studies such as Cardia and the like. So critical information that is going to help us, I believe, move forward. In which domains? I wanted to reverse the logic for the advances. I want to use the exposures, the risk factors that I described. We need to, and here I have fantastic colleagues in the sleep field working on social determinants of health, looking at actually the upstream determinants of these racial, ethnic, and socioeconomic inequalities. We are using our surrogate when we talk about Black, African-American children, or Hispanic and Latino. We need to better understand the impact on the sleep health early on and how that trajectory occurs, because we are finding that there is much more persistence than we previously believed into adulthood. From a biological determinants standpoint, I guess you'll figure that I wanted to talk about the sleep EEG biomarkers, because clearly they capture a disruption in the sleeping brain that we cannot otherwise observe with our traditional methods, be it objective or subjective. But they do require identifying the neural processes that we target. So just as an example, ORP as a biomarker of a sleep death very well may be transdiagnostic to a sleep apnea, ADHD, internalizing disorders, but it may very well also reflect very different underlying neural processes than slow wave activity or sleep spindle density, and therefore cannot be equated and cannot be substituted. In terms of phenotyping and health outcomes, I want to think that the insomnia phenotyping based on objective sleep measures, be it in the lab or at home, will translate developmentally. We provide some evidence, and that is going to help us with early detection. And in terms of sleep disorder breathing, the adult literature is doing a lot of work in endophenotyping, which means understanding sleep apnea from the pathophysiologic mechanisms that leads to obstruction of the upper airway. We need to do that from a developmental standpoint. We need to have better cumulative exposure models and even dynamic models of respiratory signals so that we can model them across the lifespan. And obviously, all this has implications for targeted phenotype matching interventions. We can match specific phenotypes to therapies. We can prevent early on if we use implementation science of already evidence-based treatments that we have. And some of the data can lead to policy changes because we can change how kids sleep and how some of the schedules that they're submitted to are incompatible with their sleeping brain. With that, as I mentioned before, I need to acknowledge that a lot of the data that I presented to you is thanks to federal funding and taxpayer money, as well as other foundations. And with that, muchas gracias.
Okay, thank you, Julio, for that presentation. I see some clapping going on the screen. Just wanted to remind everyone, if you have questions, please submit them in the Q&A. Don't be shy. We want to hear what kind of ideas or what kind of things that you would like to ask the speakers and to clarify at the end of the discussion. So if you have a question, please add it into that Q&A. So next we're going to move on into adolescents and young adults, and we'll hear from Dr. Sarah Honecker, and she'll talk about the advances and opportunities in sleep and circadian science in the adolescent and young adult age range. Dr. Honecker is an associate professor of pediatrics at the Indiana University School of Medicine and the director of the Behavioral Sleep Medicine Service at Riley Hospital for Children at Indiana University Health. She's a clinical psychologist and board certified in behavioral sleep medicine. She provides treatment for children with insomnia, circadian rhythm disruption, and other sleep disorders. Dr. Honecker also directs the Healthy Sleep for Kids research program, which focuses on detection and evidence-based treatment for sleep disorders in underserved pediatric populations. She's received a Career Development Award from NHLBI to promote timely detection of pediatric obstructive sleep apnea in underserved communities using computer decision support. Additional research examines adapting insomnia treatment in adolescents, and she's been funded by the American Academy of Sleep Medicine Foundation for this work. So I'd like to turn this over to you, Sarah, for your presentation.
Thank you so much for the opportunity to speak to all of you today. So this is a daunting task to summarize the adolescent sleep field in 20 minutes. So please forgive me for any omissions. I don't have any conflicts of interest to disclose. At the conclusion of this presentation, attendees should be able to describe normative developmental changes in sleep and circadian rhythms, summarize key areas of impairments related to sleep disorders and problematic sleep health, recent advances in sleep and circadian science in this developmental group, and finally, opportunities for advancing the field. In terms of the organization, I'm going to start by talking about developmental changes in sleep, sleep health, sleep disorders, treatment, and then implementation. As well, there will be some cross-cutting themes related to mental health, technologies, equity and patient-centeredness. And throughout, I'm going to highlight some opportunities for future work, and many of these come from the NIH Sleep Research Plan. Okay, so in terms of developmental changes in sleep, there is a circadian delay that progresses across adolescence. It's associated with Tanner stage, which is an indicator of pubertal progression. You can see here more delayed melatonin onset as one progresses through Tanner stages. Also sleep, there's an increase in excessive daytime sleepiness that is independent of insufficient sleep, and a slower accumulation of sleep drive across adolescence. Meaning that older adolescents and young adults may be more able to delay their bedtime. However, recent research suggests that there may be stability in the rate of sleep dissipation across this developmental period, meaning that the sleep need does not necessarily decline across adolescence. And so the expert-based recommendations for teen sleep duration is 8 to 10 hours, but there are some experimental studies that suggest that 9 hours might be more appropriate for optimal functioning. So I think that's a area for future study. I also want to point out that the delayed circadian phase is not just an adolescent phenomenon developmentally, and that it continues into early adulthood. So you can see here that it peaks in women at about 19 and a half years and in men at 20 years. So this is the measure of the mid sleep time on free days, and higher numbers indicate further delay. This is a model of adolescent sleep, originally proposed by Carskadden in 2011, updated in 2018. And you can see here at the top, pre-adolescent sleep. And then at the bottom, you see adolescent sleep. So due to a variety of factors, adolescents tend to go to bed later, they tend to rise earlier, and this results in short and ill-timed sleep. So the bioregulatory pressure or maturation of these mechanisms tends to push sleep later with a slower rise in sleep pressure and the circadian phase delay. Psychosocial pressures are also pushing sleep later. So things like bedtime autonomy, children choosing their own bedtimes, academic pressure, screen time and social networking. And then we also have societal pressure that that results oftentimes in early school start times, meaning that teens are rising earlier than their biology would indicate. And so essentially these forces are combining to create the perfect storm in which short and ill-timed sleep essentially has become the norm. So throughout the talk, I'm going to be referencing both sleep health and sleep disorders. So I want to briefly define pediatric sleep health. So similar to the adult model, it includes satisfaction and quality, alertness or sleepiness, the timing of sleep, sleep efficiency, and sleep duration. But unique to pediatrics is the behaviors component, and that refers to things like the consistency of sleep patterns, bedtime routines, sleep habits. And I think there's room to continue to study all of these areas, but perhaps particularly to enhance our understanding of how to measure sleep satisfaction and sleep quality and how and when it matters. In terms of the prevalence of different components of sleep health in adolescents, I'm going to share some of my data from a computer decision support system called Chica. So Chica is a system that we use to screen for sleep and other conditions in pediatric primary care. In Chica, families, when they present for a primary care visit, receive a tablet where they will answer up to 20 tailored yes or no questions about their child's health. And these are individualized based on previous responses and risk factors. And then if there is a positive screen, the pediatrician or primary care provider will receive an alert in the electronic medical record. So I'm going to show you data from over 5,000 children and adolescents. The sample is 95% Medicaid, so mostly from lower SES backgrounds. Fairly diverse sample, 55% Black non-Hispanic, 35% Hispanic, 5% white non-Hispanic. And this is the adolescent data only, so in about 2,000 kids. So you can see the bedtime media use is the norm. And keep in mind that this is not media use before bed, but at or after bedtime, so while falling asleep. 35% reported insufficient sleep, which is actually fairly low compared to other estimates in the literature. I will say that most public high schools in Indianapolis, where we collected these data, start at 8:30 a.m. So that certainly could play a role. And about 50% of kids in our sample reported daytime sleepiness often. So in thinking about which teens are at higher risk, here's some of the data by race. So these are for the full sample, but the results are comparable if we look only at adolescents. So you can see that Black children are more likely to report bedtime media use, more likely to report insufficient sleep duration, but we don't see strong effects for differential daytime sleepiness. So I do think that there are a lot of opportunities in sleep health disparities in this developmental group. So in terms of describing disparities, I think we need to understand sleep in certain minoritized groups that have been understudied, so Hispanics, Native Americans, also disparities in health service, so who is receiving evidence-based care. In terms of understanding disparities, multi-level and multifactorial causal pathways for disparities and the role of discrimination. And then in terms of intervention, so strategies to promote awareness of sleep health and disorders in underserved population, culturally tailoring interventions, community-based research. So opportunities abound. So transitioning now to the factors that impact sleep health. So this is a model that examines sleep health behaviors in the context of multiple levels or factors. So at the microsystem level, factors like race and ethnicity, age, genetics, comorbidities contribute. At the mesosystem level, so this is where individual characteristics interact with a child's broader environment. We have factors like parent-child interactions, family structure and cultural norms, school start times. And at the macro system, there are broader factors that impact sleep, like neighborhood air quality, neighborhood violence. And there's more work to be done in each of these areas, but arguably, particularly in the macro system area. So screen time is a major factor with this current generation of adolescents and young adults, and also likely future generations. And it can be tricky to understand the effects. So in a systematic review of 67 studies, an adverse association was found between screen time and at least one sleep outcome in most studies. So cross-sectionally, we are definitely seeing associations between screen use and worse sleep. Most common sleep outcomes were shorter sleep duration and later sleep timing. But again, it's a complicated picture because the impact of bedtime media use on adolescent and young adult sleep is going to depend on things like the type of device and the type of light waves, the timing of device use, the distance from the child's eyes, how stimulating is the activity, and even individual factors like eye color can impact, can impact susceptibility to light. So we know a lot cross-sectionally, but I think there's really a need for more rigorous measurement, understanding of mechanisms, and also experimental protocols. So in thinking about sleep health and COVID in this age group, again, it's a complicated picture. During school closures, we tended to see longer sleep duration, more insomnia symptoms, more mental health symptoms. The increase in sleep duration was likely driven by later school start times, at least in part, because we didn't necessarily see this increase in sleep duration in young adults who were not attending high school or middle schools. We also know that the impact of COVID differed for certain groups. So, for example, you can see here that increased insomnia symptoms were seen in adolescents both with and without ADHD, if you compare before and during COVID. However, sleep duration only increased in teens without ADHD. So there's a wealth of evidence to suggest that sleep health matters across multiple areas of sleep health and functioning. Reviewing all of these are beyond the scope of this talk, but I'm just going to give you some examples of findings that link different areas of sleep health to various outcomes. So we know increased sleep duration is associated with metabolism, circadian alignment. So in better circadian alignment is associated with improved mood, more sleep duration and better immune response, less inter-individual variability and healthy food choices, more sleepiness, more motor vehicle accidents, and less sleep duration and higher cardiovascular risk. So here's an example of a study looking at sleep health and insulin resistance by Stacy Simon and colleagues. And they found that short and late sleep, so here you see short sleep, and late sleep is related to insulin resistance in adolescent girls with obesity. So lower sleep amounts and later bedtimes are associated with decreased insulin resistance. So sleep and mental health, several talks in and of itself. We know there's a transactional relationship between sleep and mental health in terms of sleep health, sleep disorders, and circadian phase. And that disrupted sleep is not just a symptom of other disorders. And then relatedly, sleep interventions can improve sleep, but also potentially comorbid symptoms. So an example would be sleep intervention improving both sleep and core autism symptoms in kids with autism spectrum disorder. Again, many opportunities in this realm. Transdiagnostic treatment approaches that address both sleep and a comorbid condition, understanding neural mechanisms and interactions. An example is the mechanisms of sleep-related pathology and addiction risk. So transitioning to sleep disorders, in terms of insomnia, in this age group, 24% meet diagnostic criteria, 40% with symptoms. And as Julio mentioned, it is more common in girls in this age group. Restless leg syndrome, 2 to 4%, obstructive sleep apnea, 2 to 4%, but more common in Black children and adolescents, as well as those from low resource backgrounds. Narcolepsy, delayed sleep-wake phase disorder, hypersomnolence disorder. So lots of opportunities here. Insomnia phenotypes, delayed sleep phase treatment for narcolepsy and hypersomnia, personalized OSA treatment. And I'd like to take a closer look at insomnia. And I want to talk first about the impact of adolescent insomnia and how it's linked to outcomes that are so important. So one is suicidality, and you see these huge odds ratios, whereas adolescents with insomnia have a much greater likelihood of having suicidal ideation, a plan, an attempt, and this is even when controlling for severity of depressive symptoms. Insomnia is associated with increased risky behaviors like substance use and drunk driving and neurocognitive impairment as well. So these are important outcomes. So I'm going to share some of my data looking at adolescent perspectives on the insomnia treatment. So this was a survey in 2019, so pre-COVID, of more than 3,000 adolescents in English-speaking countries. And you can see this was a collaborative effort with several authors. And study respondents self-endorsed one or more insomnia symptoms. Most of them met diagnostic criteria for insomnia based on their report. We did social media recruitment. And there was an important question that we asked, which is, after asking a number of survey questions, we said, what else do you think it is important for us to know about what it is like to be a teen with insomnia? And here is a word cloud showing the responses. And we use descriptive thematic analysis to identify themes. And I'm going to show you just a few because I think it nicely illustrates how valuable it can be to directly ask adolescents some of our research questions. So one theme was that of feeling invalidated. So feeling like their disorder wasn't being taken seriously or they were being blamed for their symptoms. So this teen says, we actually have this condition. We don't just spend all night on our phones like our parents seem to think. Another theme was feeling overburdened. So this teen says the pressures are massive. And finally, feeling helpless and hopeless about their insomnia. So this teen said, sometimes someone may try something for a while, and when it doesn't work, they just give up and feel like there's no point in trying because they'll never get the insomnia to go away. And another thing we learned from some of the survey questions is that in many cases, the symptoms persist. So we saw this in Julio's data as well that showed persistence from childhood into adolescence and young adulthood. So in our sample, more than half of the teens reported having had symptoms for at least 3 years at the time of the survey. So transitioning to treatment. In adults, CBTI is first-line treatment, but what about in teens? So there are some reasons to question whether CBTI is feasible, acceptable, appropriate for teens. These are data suggesting that teens report that they are not likely to adhere to many common CBTI recommendations. And if you look at the efficacy studies, there have been more than 10 studies in adolescent populations, and the results are promising, but not well characterized. So the protocols are quite heterogeneous, making it difficult to know what is adolescent CBTI and what elements are working or helping. And so this brings us to a current study ongoing called Dream It. And this is funded by the American Academy of Sleep Medicine Foundation. And our first aim, which we're almost done with, is to engage stakeholders in an iterative process to develop content for an adapted insomnia protocol. So we've done virtual focus groups with adolescents, their parents, and pediatric behavioral sleep providers on an adapted protocol, and aim two is to conduct an RCT. And so in addition to the focus groups, we are working with an advisory board of teens with insomnia, which we call the Teen Dream Team. I also want to draw your attention to transdiagnostic treatments for sleep disruption. So many sleep problems do co-occur and interact. And transdiagnostic treatments can address multiple issues simultaneously. So here's an example. This is the transdiagnostic sleep and circadian treatment developed by Allison Harvey and colleagues. It's a modular treatment to promote sleep health and address circadian sleep and circadian problems to improve sleep and to improve comorbid mental health conditions. So you see here, there's some cross-cutting modules, things like motivational enhancement and goal setting and education. There are core models that are focused on promoting sleep health, and then there are optional models that are specific to the presentation. So it might include PAP adherence or nightmares, for example. So I think this is an important area. Also, there's really been a push to incorporate sleep education as part of school curricula in middle schools, high schools, and college. What we found is that a lot of these programs have done a nice job of improving sleep knowledge, but they're less likely to improve sleep patterns post-intervention. And those that do tend to be more effective include additional components above and beyond medication, like motivational enhancement. So how do we change sleep behavior in adolescents and young adults? I think a qualitative analysis focused on changing sleep behavior indicated that adolescents and young adults want to change their sleep behavior, but they've had previous attempts with limited success. So that helpless, hopeless theme. And some barriers include time demands, unpredictability of their schedule, difficulty switching off technology use. And there are some, and then Allison Harvey wrote a nice article that looked at proposed barriers to adolescent behavior change, as well as some solutions. Another important area. And finally, last topic is implementation. So there's a lot we do know about sleep health and sleep disorders in this population, but how much of what we know is being translated to improve people's lives? So sleep disorders may remain undetected, particularly in disadvantaged populations. And those diagnosed with sleep disorders may not be receiving evidence-based care. There's limited training in sleep, significant practice variation, and provider practice patterns are difficult to change. So definitely some areas here, novel identification strategies, designing interventions for implementation, measuring implementation outcomes. And finally, example of some implementation work that I'm currently doing is using computer decision support. So computer decision support can be used to facilitate screening, surveillance, referral, treatment, and follow-up care. And here's examples of some of the modules, topics. And currently, we are looking at detecting sleep apnea in children and adolescents. And so in addition to screening, we're looking at incorporating a best practice advisory into EPIC to see how this impacts provider referrals and identification. Okay, and many more opportunities. I would like to thank the webinar sponsors, the AESM, the Center on Sleep Disorders Research, and the Sleep Research Society, my institutions, funding sources, particularly my NHLBI K23 and the AESMF Foundation, my many collaborators, my amazing research team, study participants, my mentors, and Ashkenazi Health, where I do a lot of the computer decision support work. Thank you so much.
Okay, Sarah, thank you for that presentation. Again, see lots of hands clapping on the screen, so great job. Next, we're going to move on to Dr. Safwan Badr to discuss sleep health in adults. And Dr. Badr is a professor and chair of internal medicine at Wayne State University School of Medicine and a staff physician at the John D. Dingle WVA Medical Center. Dr. Badr is a sleep disorders researcher and mentor with an extensive record of funding, publications, and mentoring. Dr. Badr is invested in outstanding medical education. So he's mentored numerous trainees and junior faculty members who've launched successful academic careers. Dr. Badr has served on multiple national and international medical societies. He served on the board of directors of the American Thoracic Society, the American Academy of Sleep Medicine. He was the president of the AASM in 2013 to 2014, and he currently serves on the board of directors for the American Board of Internal Medicine. So I'd like to turn the floor over to you for your presentation. Thank you.
Thank you. Can you see my screen, my slides?
Yes.
Okay, good. It worked. Hallelujah. Sometimes it doesn't. Well, good afternoon, everyone. I'm so pleased to be speaking with you on this very small topic, kind of a sleep health in the adults. So I picked a few areas that I would like to emphasize. I have no relationship to disclose, no conflicts. So we'll talk about sleep deficiency. We'll outline how sleep disorders contribute to cardiovascular and other consequences. And we'll talk about how all of these conditions actually will interact. And my goal in selecting these areas is to identify a few gaps and areas where we can actually explore further, because I had to be selective in what I pick here. So I love this slide. If sleep does not serve an absolutely vital function, then it's the biggest mistake the evolutionary system has ever made. This is by none other than Alan Rakchafen. But that actually, we know that we are finding more and more. We know that why it's essential for life. So in terms of developments over the past 10 years, and I think this is where it started, is we've struggled with the whole idea of function of sleep. And the idea that the sleep facilitates removal of metabolic waste is actually relatively novel. And when I actually did a recent search on this, we're talking in terms of hundreds of publications. So on the left panel, you will see the difference in this CSF influx in a sleeping, which is in red, and awake in right, which meaning, again, it's actually facilitated these spaces, and the word glymphatics was introduced into the field, a way of actually getting the metabolic waste out. So according to this theory, which is probably now the dominant theory, it's clearing the brain of accumulating metabolic waste product, beta amyloid, which is excreted into the extracellular space, has a local toxicity, and sleep deprivation basically promotes accumulation of amyloid. Now, this idea can be expanded broadly, and the question is that as we get older, this becomes another issue. Other sleep disturbances, the relationship between sleep and cognition is a huge area that we're only starting to explore. One area that's not adequately explored is sleep disorder breathing and cognitive dysfunction and Alzheimer's dementia in particular. Unfortunately, or when I started in this field, we were fighting against this current, which is Thomas Edison, who said that sleep curtailment is a virtue. He said sleep is a criminal waste of time. And now that was the beginning of the dark ages that hopefully over the past 10 years, I think 20 years, thanks to the NIH, to scientists, to the ASM, we're emerging from this. And now we know that actually insufficient sleep contributes to many consequences. It makes you grumpy, accident prone, and obese. So what's the definition of sleep deficiency? Not enough sleep, insomnia or sleep curtailment, poor sleep quality, any of these conditions, fragmented sleep, circadian misalignment, or primary sleep disorder. That is more than a quarter of the population. So this is now cutting across. Point number two I'd like to make, we have historically put our energy into isolated silos of condition. And in reality, there is intersectionality, and these conditions actually interact. And we're dealing with this with studies we do. We think the participant will come with one condition and we're finding 2 or 3. So this is the map of insufficient sleep from the CDC. And notice that some areas are sleepier than others. So according to this, actually, nobody is sleepless in Seattle. They seem to have some of the better rates. My lovely state of Michigan is not getting enough sleep. So the metabolic aspect of this is actually critical. And I always ask when I give this talk, for those who actually stay up all night on call, and residents and fellows and hospitalists and all of this, when you get up in the morning, do you ever say, boy, I'm really craving some lettuce or celery? The answer is no. What we actually crave are carbohydrate and fatty food. So now we know that insufficient sleep and sleep duration does affect changes in leptin and ghrelin. And the top panel here is leptin, and the bottom panel is ghrelin. So leptin decreases and ghrelin increases when we're not getting enough sleep with insufficient sleep, which is in effect contribute to our increased appetite. And it shows this relationship that as sleep duration decreases, there is an increase in body weight. Now, but somebody is going to tell me, wait, we see a U-shaped relationship. This part of the U-shape has been a struggle for the field to be able to address. And we do not know whether this is causality or reverse causality, but it's actually there. So now, if we look at this is the insufficient sleep map, and this is the obesity map, and you see there is significant overlap between these two things. And this is actually messing up a few aspects in our conversation. So also my state of Michigan, we are in the 30 to 35, but there are some states here from Iowa all the way to Louisiana that have more than 1/3 of the population will meet the diagnostic criteria for obesity or BMI over 30. Now, for a frame of reference, a lot of people here are young and may not remember these days. This is what the map looked like in 1993. So there was no state that had a more obesity than 19% at that time. So these things have affected many of the changes that we have. It changes it and the question is there a relationship between these two? Now, insufficient sleep, sleep duration has significant interaction with other conditions. Look also at the hypertension map. This is a 700,000 individuals from 2 large national databases. And what you can see, again, your healthiest, your odds ratio of having hypertension at lowest at 7 to 8 hours of sleep, and clearly increases after. Again, the other part, we do not know whether that's causality or reverse causality. The other one, equally relevant, is the metabolic syndrome. This is the mean metabolic syndrome severity score, and you see that it's matching it exactly. And obviously, mortality seems to follow when these things happen. Now, the changes that we're seeing in obesity rates are actually having some other impact on the prevalence of sleep disorder breathing, for example. So let's look at the OSA prevalence and its rise over time. This is the Wisconsin sleep cohort study, this is where I trained. This is where I spent the first 10 years of my career in Madison. And the green is the numbers in 1988 to 1994. This is where the prevalence data of sleep disorder breathing. And look what happened now in 2010 with the changes of obesity rate in men and in women. The numbers, obviously, there is a gender difference, but clearly there is a significant increase. So now when we're talking about sleep disorder breathing plus symptom, which is the syndrome of sleep disorder breathing, we're talking about 5% of women, 15% of men. Again, this is all relationship to changes in obesity rate, and it's almost entirely explained by that. So as time passes, obesity is going to be a major driver of a whole lot of these changes. So one of the questions we always had is how many hours of sleep do we need to get? And it was actually the Center for Sleep Disorders Research and NHLBI who nudged all of us over the years. Folks, you really need to come up with a statement on this. And this was an ASM, SRS, and CDC collaborative project. And during that time, this was published in 2015, looked at a variety of metrics, and this is only in adults, this is not in children, looked at a variety of metrics, and green is where we actually see is good. And what you will see that in most metrics, somewhere around 7 hours seems to be sufficient. But then in some aspect like general health and metabolic health, you actually needed more sleep. The area that the data was not clear on, because the studies were fairly limited, was cancer. So this was pretty much excluded. But the point is, this was the basis for the statement that came out from this work group, which is adults need to obtain minimum of 7 hours of sleep on average to promote optimal health. And I think that there were other professional societies that came up with similar statements, but the idea is the same. So now we're talking about consequences of a disease, and that's another area that produced a lot of controversy, which is the different association. This is from the Wisconsin sleep cohort study from 2000, and this is longitudinal, and that's actually what makes it very interesting, is that over time, as you develop with the higher severity of sleep disorder breathing, the higher the likelihood of hypertension. And so basically at odds ratio of 2 or above, and this is in an adjusted model with an AHI over 15. Now, this is another area that we need to be careful as we look at different studies. Studies have defined sleep disorder breathing differently, and I'll make a comment about this later. The Wisconsin sleep cohort study defined it as a hypopnea as a 4% reduction in oxyhemoglobin saturation. Again, this is important as we compare studies. And this is where this is actually relevant. So another large study, which is the sleep heart health study, found that sleep disorder breathing predicted coronary artery disease and heart failure. However, this was only in men, but not in women. And in men for coronary heart disease, it was only in men younger than 70. And you see this in many studies. And I think this is a very important point, which is why we're seeing this. I'm going to pause here to highlight one other aspect, which is the disease that we call sleep disorder breathing or obstructive sleep apnea was originally defined and identified in middle-aged obese men. The criteria were all derived from that category. And we're continuing to evolve from that. And in that case, even some of the diagnostic criteria may actually play a role. So women are less likely to desaturate, so hypopneas that are associated with desaturation could potentially be missed. So that's we have to factor in how these things are defined and determined in analyzing these studies. But again, that reflects an area of a potential gender difference that need to be explored further. And when we talk about mortality, which is also from the sleep heart health study, this is the difference. AHI over 30 has an increased mortality. However, this was driven entirely, while you see it in the total population, in the total sample, it was driven entirely by data in men. So clearly there is a difference, and these things are often ignored and not analyzed adequately, but and kudos to the authors here that they actually analyzed it very carefully and highlighted it. So one of the critical aspects in these conditions, does the treatment make a difference? So so what I decided to do, instead of pulling individual studies, somebody has done the work, the ASM did it with the standards of practice, and this is a systematic review. They looked at the whole literature. So let's start by looking at what's happening in hypertension. In hypertension, and this is a forest plot, you will see that the aggregate of the studies, there is a slight decrease in blood pressure. And again, that applies whether we're talking about 24-hour blood pressure, systolic, diastolic, it doesn't matter. The point is that there is a small decrease. Now, the small decrease in these studies is very significant clinically. We shouldn't be fooled by the small number of millimeters of mercury. So this is actually highly significant. However, one of the issues is, what about cardiovascular events? And this is one of the major struggles in the field. We know that sleep disorder breathing is associated with adverse cardiovascular consequences. What would happen if we actually treat it? So this is one of the studies, and there are lots of studies, and they all seem to be pretty much pointing in the same general direction. And this is the SAFE trial, and clearly there is no difference. This is the cumulative incidence, and you can see a large number, 2,717 randomized to CPAP or usual care, followed by 3.7 years. And what did they find? There was absolutely no difference in the primary endpoint, the first primary endpoint. And a comment in this was 3.3 hours of PAP use only. And again, that is one example of these studies. Another equally large study, which followed for 57 months, almost 5 years, CPAP and usual care, 244 participants, and the same story, the same observation. The curve, the trajectory is exactly the same. And if you look at the majority of the studies, we're unable to find a difference. And this is also from the ASM systematic review. There is no difference. There is no evidence that treatment with CPAP improved cardiovascular outcome. So when it talks about adverse consequences of sleep disorder breathing, we know that sleep disorder breathing and sleep disorders in general are associated with cognitive decline. There is enough indication pointing that sleep disorder breathing may contribute, may be a risk factor of Alzheimer's disease. And now I'm going to throw another idea. And this is the idea of gender disparity in the diagnosis. Alzheimer's disease risk is higher in women compared to men. And yet women are less diagnosed and often missed for sleep disorder breathing. Could that be one of the aspects that there may be an element, that be a modifiable risk factor if we treat sleep apnea? Metabolic syndrome, hypertension, and heart disease all are associated with sleep disorders and sleep disorder breathing. There is a strong link between sleep disorder breathing and hypertension. There is an interaction by age and gender, and it's important that we capture it in that study. PAP therapy is associated with a small favorable effect on BP, but it's meaningful. It's small in studies, but it's actually very meaningful in terms of clinical outcome. There is really no evidence that PAP therapy results in improvement in cardiac consequences. And again, that is a struggle, and that's a surprising to all of us, Surprising to somebody like me who's been in the field for 30 years. I would expect that actually it will. And one thing that is common in this conversation is we blame the patient. We always say about low PAP adherence. But maybe there's something else. Maybe it's not the low PAP adherence. Maybe there's some other reason that this is not happening. For example, maybe by the time we're actually making the diagnosis and initiating the treatment, some of the adverse consequences are now immutable. Some of the cardiac changes are immutable, some of the vascular changes. So we must be missing something in this conversation. So now I'm going to take kind of this is the chance to look forward. So how is the road ahead here? What should we be looking at? Well, another message, another lesson I've learned from studies that we're doing is that when we look at one condition, we're actually finding more than one. We're having a clinical trial on looking at sleep disorder breathing and if comparing sleep extension versus PAP therapy. And we're finding more than a third having comorbid insomnia, that this is a very common thing. So maybe what we need to do is look holistically at the variety of the conditions that people have. So maybe what the consequences we're seeing is an interaction between sleep duration, insomnia, metabolic syndrome, and sleep apnea. And then there is one other factor that is often missed in many of the studies, social determinants of health. And how we factor that in is going to be very critical, because if we are going to develop treatments that change the health of the population, we need to understand the population. And in many of the studies that I looked, unless they were targeted on this area, this aspect actually is not being addressed. And I think this is one variable that may allow us to look very carefully and categorize the different response in different populations. With that, I will stop. I think I'm done. Thank you.
Okay, thank you, Dr. Badar, for that presentation. We have one remaining talk, and we'll move on to that one. Remember to put your questions in the Q&A, please. The next presentation will be by Dr. Brienne Miner, and she's going to talk about sleep in older adults. Dr. Miner is a geriatrician and a sleep medicine physician and researcher who's interested in improving the management of sleep-wake symptoms and disorders in older adults. So her current interests include evaluation of sleep deficiency in older persons using self-reported and objective measures. Ultimately, she aims to design interventions for sleep deficiency in older persons with and without cognitive impairment, which may lead to improvements in cognitive function as well as physical function in this population. So Dr. Miner.
Okay, thank you everybody for your attention. Thanks for having me. And I will finish up with the other side of the spectrum, talking about older adults. I have no conflicts. And I want to start just by telling you all how I got to where I got, which is I started in my career as a geriatrician. And this is a statue that sits outside our geriatric clinic where I am still working and still seeing patients. And our mission in geriatrics is to really do what we can to and enhance the health, independence, and quality of life of older people. And so this is how I really started to get interested in sleep, because in this clinic, sleep problems were very common. And as I think you all know by now, they're associated with a lot of detrimental outcomes. And what I'm interested in, rather than telling you about some of the metabolic things that you've heard about or cardiovascular outcomes, I'm interested in those things in older people that can rob them of their health, their quality of life, and their independence. And so for me, I saw how sleep problems were causing problems with falls, physical function, hospitalization, institutionalization in a nursing home, problems with mood, depression, and problems with cognitive impairment. And so that's how I became really interested in this field. So in the next part of the talk, I want to just give you a sort of quick overview of some of the things that I think a lot about in terms of diagnosing and treating sleep problems in older people. So these are the learning objectives. I'm going to describe how sleep patterns change with respect to quality, duration, and timing among older adults, and identify age-related factors that contribute to sleep disturbances in this population. And I'm going to have a few slides here to help understand how the approach for common sleep disorders may change for older adults, and then highlight some opportunities for advancing sleep and circadian science in older adults. So let's start with this first one. So you've heard a lot about sleep duration already. You've heard about this U-shaped association of sleep duration with many outcomes. This is the recommendation from the National Sleep Foundation about what is an appropriate duration in people 65 and older. So you see across the lifespan, it changes. But what I think is important to acknowledge is that in people 65 and older, we don't think that they need less sleep. The recommendation that you see here in blue is 7 to 8 hours. And that's pretty close to what we are recommending for younger and middle-aged adults. Again, because we know there's this U-shaped association, we know that shorter sleep duration is problematic, but also longer sleep duration is problematic. And the reason that we got here is that because older adults who sleep 7 to 8 hours tend to report better physical health, better mental health, and better quality of life. So that's what we think of as a normal overnight sleep duration for older people. We do know that sleep architecture changes with age, and this is independent of health conditions that might be impacting sleep. So if we focus in here earlier on, we can see some younger children that we heard about earlier in the session will be spending a lot of time in slow wave sleep, a lot of time in REM, and that as we get older, our time in those stages decreases. And so we tend to have a shift away from REM and deeper sleep into lighter stages of sleep. So this is a sleep histogram, and if we look first at the younger adult, we have time across the night on this x-axis, and then we have our different sleep stages, starting with wake, REM, the lighter stages, and deeper stages, and 3 or slow wave sleep. So you can see that a younger adult will have this cycle through the lighter, deeper stages, and then REM, nice cycles throughout the night. So what we know to be normal as we age is that we have more arousals from sleep. So what that normal sleep architecture might look like in an older adult is shown on the bottom here. And so these spikes to the top are representing the fact that older adults will have more arousals and awakenings, but those should be short. And, we think the normal course of sleep is that these are short and the older adult is able to go back to sleep easily. So circadian rhythm tends to change as we age, and what becomes very common is to have a phase advance, which means there may be a preference to go to bed earlier, and that results in getting up earlier. This is not thought to be due to changes in periodicity or tau. What's really driving this is probably changes in the timing of melatonin, dim light melatonin onset. So if we look at the blue curve here, this is what we think of as the normal sleep phase, dim light melatonin onset coming around 8 o'clock and then dissipating by 8 o'clock in the morning. So older adults, and again, this is a normal feature with age, might have a phase advance because melatonin secretion is happening earlier. And so that might result in a bedtime, say, of around 7:30 or 8 o'clock at night, and then a rise time maybe closer to 3 or 4 o'clock in the morning. And again, normal as long as the duration is normal. We know that there's a decreased amplitude of rest activity rhythm, body temperature, and many hormones. And so that, which I'm showing you here, is a difference between the peak of activity or concentration and the trough. And so what you might see if we're looking at body temperature, which really is, reflecting our circadian rhythm. On the top here, this red curve, we have a 25-year-old, and on the bottom, we have the green curve, which is a 65-year-old. And so you can see the 25-year-old, their peak temperature, 37, and then their trough, 36. That amplitude is much greater than what we see in that 65-year-old. We also know that there is a loss of ability to phase shifts, or, to think about this more simply, to change the our bedtime and our rise time as we go across time zones, for example, that becomes harder as we age. And that may be related to visual change or loss, a decreased ability to receive in the suprachiasmatic nucleus that stimulus that helps us to shift our phase. So now I'll go on to the next part, which is to identify age-related factors that contribute to sleep disturbance. So I think about these a lot in my clinic. I look for these a lot. The first one is medical and psychiatric disease. So simply, as we age, we tend to collect conditions. And so you can see here, as we age, the prevalence of multimorbidity or having at least 3 chronic conditions increases. And so someone who's 85 and older, probably 82% of those people are going to have multimorbidity. We also know that sleep problems increase with multimorbidity. So what you can see here is that for older adults with at least 3 chronic conditions, nearly 70% of them are going to report a sleep problem. So medical and psychiatric disease and sleep problems go hand in hand. The other thing that I think about a lot in older people that may be impacting their sleep is medication use, because medications can affect sleep in many different ways. So I'm going to highlight a few domains here. There's daytime drowsiness. For example, antihistamines, pain medications, or benzodiazepines can cause daytime drowsiness and therefore make it harder to initiate or maintain sleep at night. You could be on an activating medication, a nasal decongestant like Sudafed or a steroid that makes it hard to initiate sleep at night or maintain sleep. You could be on a medication that worsens sleep disorders. And so I spend a lot of time thinking about this when I'm seeing patients, and I spend a lot of time educating my residents and fellows about this. So the most common examples are things like antidepressants causing restless leg syndrome or REM behavior disorder. And of course, another common example is being on a Z drug like Ambien and that causing parasomnia. So I always look at the medication list when I'm seeing an older person who has a sleep problem. And then finally, you might be on a medication that causes a sleep disruptive symptom. So that would be a common example here is an ACE inhibitor causing cough, a water pill causing you to urinate at night, or a medication for diabetes causing low blood sugar at night. Another thing that's not unique but becomes more common with age is having more of these psychosocial behavioral factors that could impact sleep. So I've listed substance use here, and I think a lot about alcohol, nicotine, and caffeine. I think it's common that people think about alcohol helping them to fall asleep, but they don't necessarily realize that it can wake them up in the middle of the night. And I think another thing with these substances is that our ability to metabolize them as we age changes. So what we could tolerate without disrupting our sleep in middle age might not be the same as what we can tolerate without disrupting our sleep in older age. I've pointed out caregiving here. I think a lot about this because I work in a geriatric clinic, and I'm interested in helping sleep problems for my patient, but also the family that's trying to take care of them. And the fact is that 1 in 5 caregivers in this country is over the age of 65. And that might be directly disruptive to sleep, or it might be the burden of that role that is sort of indirectly affecting sleep. And then, of course, bereavement, very common in this age group. And then I want to talk about social isolation and loss of physical function. Again, not unique to this group, but much more common. And how do these affect sleep? Well, one clear way is by causing poor sleep hygiene. Maybe less physical activity during the day, more napping during the day, that can impair sleep. But then we also know if people are isolated, they have problems with physical function, they can't leave the home, they are getting inadequate exposure to zeitgebers. These are cues from the environment that really sort of cue our circadian rhythm. And so here I'm showing you the most common one that we think about is light, a photic zeitgeber. That is sending a message to our suprachiasmatic nucleus, which is keeping time for our body by signaling to all of these peripheral organs in our body and keeping everything on a schedule. But there are also non-photic zeitgebers, non-photic cues that are also important to maintain our circadian rhythm. These are things like physical